Well, welcome along to this week's Coaching Corner. Today, our topic for discussion is a 6-step plan to develop ultrasound competence. We often get asked the question, how do I go about getting the skills once I've done my course? Or, you've got started on your ultrasound journey, but then what do you do to keep it on track, and how do you keep developing those skills? And so I wanted to sort of walk through a 6-step plan. First thing we're going to do is choose a topic. So that can be a specific exam you want to perform or a specific clinical question you want to answer. So some examples might be, I want to get good at a FAST exam, or I want to get good at being able to answer the question, is there an intrauterine pregnancy? And my advice here is to focus on one thing at a time. When you focus on one thing at a time, you focus your energies, you get a lot more consistency of practice when you're just trying to figure out one topic at a time. My advice again is also to think about something that you either want at high frequency, so a clinical question that comes up a lot, and what happens if it's high frequency, you get heaps and heaps of opportunity to practice it, or choose something that has a big clinical impact. So if it's something that's going to make a massive time saving on the management of your patients, or is going to, the results are going to help you manage your patients much better and in a more efficient way and have really good outcomes for the patients, or be able to just make that decision quicker. If you've got something that's high clinical impact, then it helps to motivate you and keep you on purpose when you're doing the scans. So something that's high frequency, because the opportunity to practice is there. And focusing on one thing at a time allows you to experience success at that one thing. If you're trying to do like 10 different topics, or even just 4 different topics, there's many, your practice is much more spread out. You've got lots of different things. You don't get good at any one thing. And then you get kind of demotivated because you're not making any headway on anything individually. The next tip is to deconstruct the scan. And the goal here is to break that examination or that skill down into the very separate learning parts. So much like when you're building a Lego set, I'm a bit of a fan of Lego, but much like when you're building a Lego set, you don't get this fancy big Lego set with all the pieces in one box all at one time. Lego is very good at giving you tiny little packets and then having you build that first packet and then putting it down, get the second packet, build that, put those 2 packets, those 2 constructions together, and slowly your Lego shape takes form. And they come with very clear instructions as well that guide you in how to put that thing together. So then all of a sudden this really insurmountable task of this massive car, or my favorite thing in this slide that I had for you was a VW combi van. If I just got all those pieces in one box, I'd never be able to make the shape of a combi van. But when you follow the instructions and you do it piece by piece and then put those pieces together, all of a sudden you're capable of more than what you thought you were. And so the advantage of breaking it down into those minimal learning units is so that you get good at one particular view before you move on. Again, you get that chance to experience success. And the reason that that's all important is to manage our cognitive load. If you are trying to do, and I used to make this mistake a lot when I first started teaching sonographers, we'd going to do an abdomen exam and they didn't even know what the buttons were. And we'd just start teaching an abdomen exam and the poor students would go home completely bamboozled. And so by doing one step at a time, you manage the cognitive load and you get to experience success. So some examples here would be the focused echo exam. You can break that into five separate parts. It's telling me my audio quality is really crap. Can you still hear me? No?
It's actually fine.
It's still okay.
Yeah, it's good.
It is okay. Okay. Chris, thanks for joining us. I'll let you know that we've got a real audio problem, which is why we're going sans presentation today. Anyway, so if we're looking at the echo study, for example, it comes nicely packaged up as 5 separate views. You've got the parasternal long axis, the parasternal short axis, the apical 4, subcostal 4, and the IVC. So just practice just the parasternal long axis view for the time being. Do 10 cases of that before you move on and practice the parasternal short axis. Get your numbers under your belt there and then move on to the next thing. If we did the same thing with the first trimester scan, for example, it might look like a survey scan, so just scanning the pelvis, looking for free fluid. That's step 1. Step 2, let's just scan the ovaries. They're elusive little buggers, so let's just get good at finding those ovaries and trying to determine whether there's an adnexal mass. Step 3 might be to look for the gestational sac, and then we can move on to measuring the fetal heart rate and confirming viability. And lastly, by the time you have all those steps under your belt, you've developed some probe skills. So the crown rump length starts to be an easier thing to achieve. If we broke down the EFAST exam, again, this comes in self-made little parcels. So you've got the right upper quadrant view, the left upper quadrant view, the pelvic view, the heart view, the lungs. They come in little packages. So just attack one little package at a time. So my third step in the 6-step plan is to set yourself some goals. And in setting some goals, what we want to do is get you focused, really clearly focused on what it is that you want to achieve. If you can be really clear about, in 3 months, I would like to be able to do a focused echo scan and be able to get the views quite confidently. And if you can write that down and be clear about what the actual goal is, then it makes step 4 a whole lot easier, which is make a plan, and we'll get there. But when you're setting some goals, everyone's heard about SMART goals being quite specific and measurable and attainable or achievable. They need to be relevant and time-bound. So being specific about what it is you want to achieve, setting yourself a realistic goal so that it actually is something that you can achieve in the time frame. Otherwise, you just get dejected and feel like you're failing. And setting a time limit on it also helps you get some focus. So some examples here. In 1 month, I want to achieve X. Or by the end of this week, I want to have done 10 scans of the right upper quadrant. So set some, only you can decide what works in your individual practice and what's actually achievable. Some of you might be working full time. Some of you might be working 1 day a week. Some of you have got other responsibilities that you've got to share your life out amongst, and you can't just concentrate wholly on ultrasound. So it's setting it up for your own particular circumstances and getting quite clear and specific about what it is that you're trying to achieve. Another way to set a good goal, or what I try to encourage people to do, is set a goal of how they're going to go about getting 20 hours of scanning practice. Everyone's heard that, you know, 10,000 hours to make an expert, or 10,000 hours to master a topic. If you're Roger Federer, you've probably done at least 10,000 hours. I think you'd probably do a lot more. But, you know, we don't need to be the Roger Federer of tennis or the Roger Federer of ultrasound to be clinically useful with the ultrasound machine. And if we set that goal at a 20-hour time limit and make a pre-commitment to how am I going to get that far, 20 hours is enough time to figure out whether this is your thing, to figure out whether you can actually achieve some stuff. And by the time you've done 20 hours of practice, you're getting comfortable enough to at least be enjoying the process or making headway. So if you wanted to learn a new language, 20 hours is going to get you into a position where you could order dinner in a foreign country. If you wanted to do the tango, 20 hours hopefully will keep you from stepping on your partner's toes. So making a pre-commitment to attaining a target of 20 hours is a great way to guide your scanning practice. Having that target in mind and being quite specific about the goals means that you can set yourself a plan and make a plan for how you're going to achieve it. failing to plan is like planning to fail, and we've all heard that analogy before. And so often I see that people just sort of think that they're going to go back and serendipitously be able to do an ultrasound because I might be able to use it on this patient, and there's just this aimless wandering and no sort of specific target in mind for how to approach that scanning practice phase. And so it's important as you make that plan to identify any practice barriers that might be in place that are going to stop you from achieving your goals. If you know that you don't have enough time, you're going to have to figure out, well, how do I make time? If you know you don't have access to an ultrasound machine, then you need to figure out, well, how am I going to get access to an ultrasound machine so I can practice? So if you can figure out what those practice barriers are, it might even just be you don't have support from your colleagues. How can you get them on side so that they can support the fact that you're trying to gain these new skills? If you can identify those practice barriers, it makes achieving the goal a lot easier. And if we're looking at that goal of 20 hours, you know, the plan might be I want to get 20 hours of practice in 3 months. Well, how do you go about that? If you were to spend 5 minutes scanning each one of your patients, you would need to do 20 minutes of scanning per day for 3 months. Now, let's say you don't have 20 minutes each day. That's 4 patients a day on a 5-day week schedule. Let's say you don't have 20 minutes a day within your clinical practice to dedicate to developing the skills. Maybe a more realistic target for you is I can only do 10 minutes a day. Well, if it's 10 minutes a day, it's going to take you 6 months to get that 20 hours of practice. But if you know how long it's going to take and how you're going to go about getting this practice, and you can add that up, then it helps you to be able to plan and make progress on your journey to competence. Now, the next step is to get to work, and that is get down and dirty, get your hands in there, get gel on the fingers, and get to the scanning work. And it's really important here to be deliberately and purposefully practicing. When you're practicing getting your pictures, and I mean practicing for practice sake, not to do a clinical examination and get a clinical diagnosis and then manage your patient, but practice for practice sake. While you're practicing, you're trying to practice and get good pictures and get good probe movements and be purposeful in your probe movements. And that takes some real deliberate practice to get to that point. You start to make incremental improvements. And the thing about deliberate practice is doing a little bit, but doing it often so that it makes it easy to work into your day. And I recommend setting aside like 5 minutes. Setting a timer, spend 5 minutes with your patient. If you can't get a good view in 5 minutes, trying to scan them for 20 minutes to get a good view is not going to help you. All it will end up doing is undermining your confidence and making you very hesitant to get the probe out next time because you haven't had any chance to experience success. So set the timer for 5 minutes and just practice for 5 minutes. Practice for practice sake. The next tip that I have for you, hang on, I'm just going to mute some people here, sorry. The next tip is, as you're doing that 5-minute practice, is to repeat it. So you might get the view. Let's say we're concentrating on just obtaining a right upper quadrant view. Get the view. Figure out, look at where your hand position is. Note, some patients might have a freckle or a skin tag or something so that you can go back to that point if you get lost, but pick your hand up off the patient, get the view again. Move the probe and practice purposefully going through each of the probe movements. Hand off the patient, put your probe back on again, and get the view again. And this time, take notice of how you're actually getting that picture. In the end, you're trying to, if you could write down instructions for what you did, where did you place the probe, what did you do next, what did you do next? If you could notice your movements and how you got your image, and you could write down the instructions for yourself, it makes it more repeatable for next time. And that's not to say that every single patient has the exact same sequence of maneuvers, but a lot of the time there's a lot of similarities and there's a structured way you can go about doing it. So you need to get the view, hand off, get it again, hand off, get it again. And you're getting that deliberate and repetitive practice that helps you develop the skills. When you get a good view, practice going through each of the probe movements and noticing what happens. If I slide my probe, what happens? If I rock my probe, what happens on the screen? Oh, that puts things in the middle, right? If I'm sweeping through and moving the probe across the short face, what happens to my image? And starting to build up that pattern recognition for action and consequence of the probe moves. And the more you can do that and take the time to deliberately and purposefully go through that, means that you start to be making those intuitive movements much, much sooner. The other thing, while you're practicing, I think it's really, really important to be a bit fussy about which patients you're going to practice on. First of all, when you're doing ultrasound, you need to establish what normal is. If you don't have a normal reference point, it's hard to know when something's abnormal. And I think one of the hardest things when you're out there in clinical practice and you jump straight to the finish line of the marathon is that you're trying to go out there and use ultrasound clinically to get an answer on a very sick patient who's got abnormal images, and you're trying to piece all that information together. And so I think it's really important to be fussy about your patients and try and pick easy patients. So someone who looks slim and looks like the odds are stacked in your favor that you can get a picture, and that they're thin enough so that it's going to be reasonably easy to get good images. That helps you establish your baseline. But the next step of that is to pick patients where they haven't got heaps of pathology. They're not super big or super thin. That increases the complexity of getting the images. So not only do you start with a baseline of normal imaging, but you also get to practice on easier patients and experience the success of getting an image on someone who it is actually possible to get a picture. So if it's cardiac ultrasound that you're doing, probably not starting with desperately sick patients is a good idea. Maybe it's someone with vague chest pain that might have gallstones, but you're not expecting any problems in the heart. Scan those people. Get your reference points for what is normal and how to scan first before you start testing out those skills on more difficult cases. And the next step of getting to work and getting scanning is to build it up. So if you've got those 5 different steps, and for the fast scan, right upper quadrant first, left upper quadrant second, then you can move on to, once you've practiced each step and got some numbers under your belt at each stage, then you can start joining together those steps. So put step 1 and step 2 together, step 2 and step 3 together, and so on, to build up the exam. And we're still going to set a 5-minute timer. And by setting that 5-minute timer, it's not then really intrusive in your clinical workload and taking up all the time, so that your colleagues are getting frustrated because you've always got the ultrasound machine out and you're not helping out with the rest of the patients and the clinical load. It stops being really, really intrusive, and it starts to be just part of your practice. And by setting that framework around the 5 minutes, it's much more realistic, because by the time you build all these steps up, it should only take 5 minutes or so for a point of care scan. Another thing while you're in the get to work and the practice phase and scanning for scanning practice sake, is to keep a logbook of your cases. And that's just sort of as a way of keeping a tally of how you're going. If you've done 10 cases and you're still struggling to find the ovaries, that's normal. But if you've done 100 cases and you still haven't seen some ovaries, you probably need to get some further help and to get some coaching. So if you can keep a logbook of your cases as a sort of a guideline of how you've been going, and use those notes to compare against other imaging tests to see how did you go, did you come up with the right answer, that can help with your reflective practice and building up those skills. And the 6th step in the 6-step plan is just to stick to it. And in this case, the law of consistency says that if it's motivation that gets you going and discipline that keeps you growing. And so it is about being disciplined, about making time to practice, practicing for practice sake, and just keeping going with small frequent bursts of practice to build up your skills. I don't know if anyone can remember getting their driver's license, but I know here in Victoria we have to get 100 hours. And, you know, it seemed 120 hours, I think, and it seems like such an insurmountable task. But I know certainly when I was getting my driver's license, I was constantly nagging my parents, oh, I can drive you to the shop, or I can drive you. Can we go somewhere so that I can drive? Because getting your driver's license meant independence. And so that practice for practice sake mindset was in place, and it helps you, you know, slowly tick up those hours. They steadily build until all of a sudden you're at the hours limit. And so if you were to approach your ultrasound scanning in a similar way, that you're just looking for reasons to practice, short, sharp bursts, and frequently, and just being very directed while you're doing them, those hours start to build, and so do your skills. And the important thing about the learning curve is that most of the learning happens in those first hours. After that sort of initial 20 hours or initial 50 or 60 cases, the incremental gains sort of plateau out. And so, you know, getting frequent practice, short, sharp bursts, being disciplined about trying to find a reason to scan someone, that's what's going to help you get across the line and build up towards competence. So the 6 steps that I've gone through is first to choose a topic, second to deconstruct to the exam, third to set some goals, 4, make a plan. Then you need to get to work on the plan and practice for practice sake. And last but not least is having the determination to stick to the plan and to keep finding those reasons to get out there and practice so that you get to competency. It's like kind of building a fire. If you have ever built a campfire, you've got to collect the wood, make sure it's dry wood. You've got to set it up just so. I've never been very good at this, but you've got to set it up just so that it's nice and aerated. And then you get your big logs on, and then you've got to try and get the match to start. And getting the fire going actually takes a whole lot of effort. And once that fire is burning, all you need to do is just keep feeding it frequently to keep it going. If you let the fire go out because it's been 3 weeks since you had a go, or, you know, I haven't touched the ultrasound machine for the last 4 months, and now it's a much bigger task to get going again. So think about your ultrasound skills as like keeping the fire burning. Give it food often so that it can keep growing. And hopefully those 6 steps can translate, whether it's your teaching others and how you set up a teaching program, or whether it's because you're out there trying to get your skills up to a competent standard. Has anyone got any thoughts or any of those tips that they've tried before that they'd like to share with our listeners?
Suean, this is Brian. I thought that was an excellent talk, by the way. Lots of great tips. I have to admit, I think the major challenge a lot of trainees find with the emergency trainees is that there's a lot of competing priorities going on at the time. And not only have they just taken a course, but they've come back to work. They're worried about taking exams. They've got a family at home, and balancing, you know, how can I try to develop those ultrasound skills amongst everything else that's going on. So I find that being self-disciplined would be ideal, but at the same time, trying to find a mentor or somebody that can help guide you at your local institution a bit is probably helpful. And I don't know what you think about that. But the other thing that I'd ask you about is a lot of times people look to external bodies for credentialing or as a means by which they can try to get a logbook going and maintain some competency or skills. What do you think about people doing CCPU modules, thinking that that's going to make them competent?
That is a very loaded question. CCPU at the moment, I think, is quite challenging. Some of the new regulations that they've put in place have made it all but impossible for people to be able to meet the standards. I'm certainly very disappointed that there's no scope for the experts in ultrasound sonographers being able to help supervise. And the thinking behind this is that the because sonographers are not clinicians and are not using the information in a clinical way, we're not in a position to advise. And I'm kind of the opinion that if you haven't got a good picture, you're not going to get the right diagnosis. And if you can't get the right diagnosis, you can't manage the patient properly. And who's the best at being able to get you the best pictures and get you to scan really well? Sonographers, or people who have a whole lot of clinical experience. So that's one of the problems. The other problem that I think is a little bit prohibitive at the moment is the idea that it's 100% clinically indicated scans, and that there's no scope here to do some scans and to have any of the scanning practice that you might do along the way count towards getting competent. I also think the numbers are a bit light on for true competency. I think the numbers, I've asked many questions over the years about where the number 25 came from, because a lot of the units have a requirement to get 25 cases. And I think it stems back, the best that I can figure is that it stems back to when the Americans brought out the Milestone Project. They had, I think, 14 different topics, and they had to try and get roughly about 25 of each. And over their fellowship, it was 200 to 300 exams that they got. And 25 in each thing, but the cumulative cases across everything was 300 scans or so when you're learning ultrasound across all those platforms. I think if you were just doing eFast and you only had 25 cases under your belt, I don't know too many people that I've seen that have reached competency doing that. So I think the numbers are a bit light on. And certainly the evidence elsewhere in the world, the Canadian Point of Care Society, they ask for 50 determinant cases. There's no sort of stipulation around how many pathology cases versus normal. It's 50 determinant scans. I was reading some AIUM guidelines for the use of bedside ultrasound by various different craft groups, and they talk about 300 cases. So some of them were 150 and some were 300. So I think the utility for CCPU is it's a great entry point and it provides structure.
Yes.
And
having it provides a structure and a motivation for people to at least get started.
Yes, I agree 100%. And it gets started.
25 scans is not competency. Exactly.
No, and having that structure, whatever process you choose, if you're answerable to someone in a formal way, like when you get your medical degree, right? You have to do your exams and stuff so that we get to a minimum standard that's in the interest of patient safety. Whatever process you use, if you're going through a process and you're answerable to someone externally to sign off on that process, you take more care along the way, and by going through the process, even if it is a pain in the backside, that does increase your skills. Whether 25 scans, I don't think 25 scans on its own works. And there are structural changes to the CCPU that I think is making it incredibly difficult to achieve. And I don't think it's in the best interest of patient safety. I think Chris had his hand up there. Hello, Chris.
Hi, sir. Yeah, I was just surprised to hear. Maybe it's just from your point of view about what you were saying about the sonographers not being qualified. I think I totally agree that they're more than qualified. And when I was first doing my my diploma in PGC in medical ultrasound, they were my mentors, and they are the best mentors. And I often say that. We are like the young Padawans, and really the sonographers are the Jedi Masters. And I think it's beautiful just watching a sonographer, how they fly, their fingers fly around the machine and drive the machine. So they are, to me, the best mentors. Yes, sonographers, some most of our sonographers in the UK don't practice lung ultrasound. So there's some bits that we can specialize in.
Yeah.
But I think the basic skills like fast scanning, echoes, etc., they are the best. They are the masters, really.
I think that point of care ultrasound is almost like a new subspecialty, like obstetrics is, like vascular is, and point of care ultrasound is like a new subspecialty. And I know in my experience in teaching point of care, and even when I'm hiring sonographers, they have the skills that I need insofar as they can do ultrasound, but they're still quite there is a gap to jump to be able to use it at the point of care and to look at it from a clinician's perspective. And no, we're not diagnosing conditions. Well, we do diagnose conditions, but we don't have to put our name on the on the report to be clinically responsible for it. It's always got the backing of the radiologist, but it's we're making those kind of decisions all the time. We might not be then prescribing drugs or deciding what next steps are, although we have knowledge of it. But it does come back to, if you can't get a good picture, how do you get the right diagnosis? And if you don't have the skills and expertise at getting the good picture, and I just don't think it's in the scope of the society to be adjudicating your medical skills. They're supposed to be, in my personal opinion, they're supposed to be looking at your ultrasound skills. And like you say, I think sonographers are very well placed, and it's a career pathway that you can expand your practice to be looking at it from the clinician side, and it makes you a better sonographer anyway by doing so. But it is kind of a touchy political topic, particularly here. I spend a lot of my week talking around this very issue. Frustrated clinicians who, unfortunately, with that change in regulations, there's kind of this black hole, because particularly in emergency medicine, the Emergency Medicine College has a framework for credentialing, but no one to really police it. And so they leave it up to the individual health authorities to police it, and that requires a lot of resources to create the program so that they can be doing the credentialing. And so they've got the guidelines, but no one to police it. The other way, we've got the mechanism to police it, but just a almost unachievable pathway to attain it, because there's just not enough people on the ground with the appropriate supervision qualifications to be able to pass it on. And so, what happens now is that we have a whole cohort of people who are spending a lot of time getting the ultrasound skills. And if you're a new registrar, you'd love to be able to put that on your CV and have a piece of paper that rubber stamps the fact that you've gone to the effort to be competent at this, that might elevate your position if you're looking for a job of choice at a new institution or whatever. And it's impossible to do that. So they can put in a whole lot of time, but not necessarily be externally recognised for it. And a lot of the hospitals haven't got an internal mechanism to rubber stamp it. And that's so it's just this horrible mess at the moment, and frustrating because there are no regulations really that are workable.
Well, the way we do it here in my hospital is we have a fellowship program. And so we send our fellows to a university called Teesside University. And so my fellow ultrasound fellows can get a postgrad certificate in medical ultrasound. So, yeah. You've got your Zedu coaching program. So I would say, if I had a fellow, I would send them to you. If I would. Yeah.
They can get in the country at least.
We don't cover travel expenses, unfortunately. So we actually, for our trust, we cover their PG certificate fees, but not travel expenses, because they have to travel a few miles up north to do some face-to-face stuff. Mm. And surprise, I send my fellows to a ultrasound department to get to do a whole day session. At least once a week for 32 hours. So 32 days of ultrasound. So that's 32 times 9 hours of scanning, just purely scanning. So that's away from the department. So we give them the protected time. So then they get and to me, I don't send them to a focused physician. I send them to a sonographer.
Yeah. Just out of interest, Chris, how much would your postgraduate certificate cost for a year of study?
Teesside's pretty cheap, so that's good. Oh. So it's about, I think it's about 2,000 to 3,000 pounds, British pounds.
We do have like a postgraduate certificate that's offered in Australia through Melbourne Uni, but we've just had people through this week who have done it, and the problem that they see there is that the theoretical component and the adjudication of their knowledge is really, really good. but you can do the whole program and not necessarily have to do any practical. So you've spent, and it's expensive. So you spend all this money, but you come out at the end and you still can't actually scan.
So part of the caveat for is that they need a mentor. You know, as one of the previous people online mentioned, finding a mentor is the most important thing. Finding that co-pilot to watch you scan, absolutely. Tell you when you got it wrong.
And that's a big sticking point, I think, and a problem with the CCPU here. The new guidelines that sort of say you must be a radiologist. A lot of radiologists I know, especially in Australia, don't scan. So they can't help you.
They don't do lung ultrasound.
They don't do lung ultrasound and they don't do cardiac ultrasound. But because they've got Ranscar behind their name and they're a doctor, they can qualify and they can be your supervisor. You have to have a CCPU in the unit of study, and that's great. So EFAST is probably not too bad. Basic echo and life support units, not too bad because there's quite a few people that have it. But some of the other units like first trimester ultrasound, gallbladder, there's not a whole lot of boots on the ground that actually already have that CCPU that can supervise. And the radiologists aren't particularly interested in assisting other people to get these skills by and large. Or a DDU. And so in Victoria, I think we have 3 or 4 emergency DDU holders. Now, they are really, really good at ultrasound, but it's the same few people, because of their passion for ultrasound, that are on all these committees that are so overwhelmed with all these other responsibilities that they haven't got a whole lot of time left over to supervise people. And they can only supervise so many people at a time. And they have to have 2 years post-DDU qualification experience before they can be a supervisor. So, you know, I think it's been a backward step to remove the ability for sonographers to be able to supervise, and any person that is currently DDU qualified or CCPU qualified has probably had significant input from sonographers to get to that point. And so to invalidate that, it's a bit of a bugbear for sonographers, let's say.
We touched a nerve there, didn't we, Suean?
Hey, yeah, well.
Can I just change the subject really quickly? I was hoping to just pick your brain about one thing, if that's okay.
Yeah, absolutely.
This whole thing, how you talked about how to develop competency in point of care ultrasound. Do you think that it's somehow changed for the more experienced, for example, face some emergency specialists that are out there for a decade or two who are, their clinical shifts are rather busy and they're supervising lots of junior staff? Is there any way that you think that these 6 steps perhaps should be modified or changed for that group of people? Because they're often, the old generation's often the ones that are most difficult to get on board.
Yeah, it's interesting, and it's a tricky dance here, because from when we're teaching, whether you're an experienced FACEM or first year trainee, for us, you're a novice ultrasound user and you're going to go through those same pain points. In some respects, you know, not scientifically proven, but just anecdotally, if you're starting ultrasound later in your career, it can actually be harder for you to get this skill, because I don't know whether it's plasticity of the brain or your spatial awareness, I'm not sure, but it can often be quite a lot harder. And particularly, like, let's say vascular access, if you've done 25 years of your career blind access, to not look where your needle is going and suddenly look at a machine and a screen over here is very, very counterintuitive. And so it's like, oh, well, I can already do it, doing it blind. Why would I look at the machine over here? And so from the point of view of how it incorporates clinically, I think the older clinicians have better clinical experience to kind of put it in the right perspective and to understand where their limitations are. But from a skills development point of view, a novice user, I think, is a novice user. And the handicap for the junior doctors is that if they get good at ultrasound, that ultrasound becomes the be all and end all, and then they forget to be a doctor to start with and to put all the pieces of the puzzle together, with ultrasound being one of them. So they overemphasize the importance of the ultrasound scan because that's what they trust, and they can not see the wood for the trees because it's all about the ultrasound. Whereas an experienced clinician has got the clinical skills to have a better perspective about it. But from an actual hands-on skills point of view, I really think a novice user is a novice user, and you still have to go through all those steps and those pain points to get to the other end. I don't know if that helps, but
yeah, I agree with that. I find that trying to teach an old dog new tricks is a bit tricky, and I guess the one challenge I know that they have is they're often quite busy on their clinical shifts. And one of the things that, as the sort of director of emergency ultrasound where I am, is trying to encourage my FACEM colleagues to allow me to take them on a scanning hour or try to get them some competency. And they often find it a bit awkward because it's one of those things, and I'm the same, take ultrasound away. But if I had one of my colleagues trying to teach me how to put a plaster on the correct way, I'd feel a bit awkward, as though, oh, geez, I should probably know this already.
yeah.
Or manage a ventilator better, you know. So it's, well, you sometimes have to swallow your pride. There's so much in emergency medicine, such a huge scope of practice that you know, we all have things to learn, I guess.
Well, absolutely. And Peter just commented on the sort of medico-legal implications of not using ultrasound is also quite an important factor. I think it was Mike Blavis who did a study, and I'm not sure how long ago, but he was looking at the medico-legal implications in the States. And there were more successful lawsuits because ultrasound wasn't used when an ultrasound machine was available, compared with using ultrasound and coming up with the wrong answer. So it's a really valid point, Peter. It is challenging. I think one of the things that, and we didn't understand this for a long time here, we used to really commonly, and still do, get good feedback about, you know, oh, it's a non-threatening environment. I've had a professor of obstetrics come from England because he kind of missed the scanning boat, and he was a gentleman in his 60s, and he came to Australia so his colleagues wouldn't know that he was doing an ultrasound course to get around that exact point, Brian. So I get it, and you know, from what I understand about the hierarchical nature of medicine, that it can be quite hard. The further up the ladder you get, the more expertise you're supposed to have, and then to all of a sudden, if you've missed the boat, it doesn't make it any easier. Just because you're more experienced, you've still got to go through those early. You've got to crawl before you can walk. So yeah, it is a real tricky problem. And like I said, the feedback we've had about the non-threatening environment, we only had, was it last week or the week before, where we had, I think, 5 consultants and 1 junior doctor who was like, oh my God, I just feel really intimidated. I'm like, you're probably going to pick this up the easiest. And, you know, by the end of the course, everyone was on a level field because they'd all just been working together to develop the skills. But I get it that can sometimes be a real brick wall that you can hit. Does anyone else have any other questions? Otherwise, we might wrap it up. I'll just check the questions thing. Chris, I use that phrase all the time, Chris. A fool with a tool is still a fool. Absolutely. I'm not sure who said that first, but I love it.
It was an American.
Yeah, absolutely.
If you Google it, you'll find his name. Yeah, he was an engineer.
Yes. Anyway, all right. Well, thank you so much for joining me tonight. Thank you for persisting with all the technical detail and difficulties that we've had. I really do appreciate your support. I think I have made a list now of what the next topics are coming up. I can't remember them off the top of my head, but if you have any suggestions, now's the time to get in. And other than that, thank you so much for joining me, and hopefully we see you all again next month.